Give everybody a minute to come in. Number is coming. Welcome, everybody. Welcome in. We will get started in a second, just giving folks a few minutes to come in. All right, it slowed down a little bit, so I'll get started. We want to welcome everybody to the Social Workers Confronting Racial Injustice Conference. We are really excited to welcome everyone back into our breakout sessions for this afternoon. We hope all of you who are here got to see our opening plenary session with Rayshawn Miller, but if you missed that, you could see other breakout panels later. All of our presentations are being recorded and they will be available later on our conference website. So if you miss anything, if there's other breakouts you want to see, please make sure to come back to watch the recordings when you have time. Want to introduce myself. I am Bethany Matson. I'm happy to be here for our breakout presentation today, titled "We Save Us: Outcomes Through Community-Based Care." We have an amazing panel lined up here for everyone, and we hopefully have a really great and interesting discussion. So as a member of the planning committee for this conference, I want to ask that you join me in, again, acknowledging that our University of Wisconsin-Madison campus here on Lake Mendota resides within the sacred homeland of the Ho-Chunk people, a place they call Dejope, or the Four Lakes. As the reach of the university extends to the far corners of our state, we also respectfully recognize the inherent sovereignty of the 12 First Nations of Wisconsin. So whether you are watching from this land of the 12 First Nations or more distance, we encourage you to learn about the land that you are on. And for those of us who are social workers and in the social work field, we always have a duty to look critically at the role our profession has played in the attempted cultural genocide and destruction of Indigenous families. And that this conference is rooted in that critical reflection of our work as social workers. So just a few things as we get started. Again, the presentation is being recorded. There was information provided about CEUs. And again, if you registered for the conference, then you are all set. When you access this presentation, you are required to provide your name and email. And so this verifies your attendance and you will get CEUs for the presentation. Your cameras and microphones will remain muted, but we do have the Q&A feature here. So if you have questions, please feel free to use that box and we will get to them as we go through our presentation today. And so without any further ado, I'd like to take a minute to welcome our panelists. We have today here Adrian Jones, Jessi, Kendall, and Tia Murray. And I am going to let each one of our wonderful presenters take the time to introduce themselves, who they are, the work that they do, and let us know about them. So I will go ahead and first pass it on to Tia to get us started.
Thank you so much, Bethany, for getting us popped off this afternoon. So glad to be here with you all. Yes, I won't talk too much about myself because I'd rather spend time talking about the great work we're doing in the community. But I am the founder and CEO at Harambe Village Doulas. And, really for me, I realized my journey in respect to reproductive justice work started with my first pregnancy at 18. Midwifery care and birthing centers changed my life in a lot of ways, and access to that higher quality care really made a difference for me. And I went on to have 4 more children, and I'm now raising 5 children right here where I'm born and raised, and really felt a calling after graduating from the UW with a degree in sociology to really get into the community and support families in the way I knew families needed to be supported. I was working in a social service agency and really was torn by the restraints and limitations we have to really truly work with families in respect to intervention and prevention, particularly families of color, in the way that we know families need to be supported. And so this idea of community mothering was something that I grew up around right here in Madison, and I wanted to get back there, and was able to start a Harambee Village Doulas so that we could create a hub for other mothers, women of color, to share their birthing stories and to come together around a common cause, such as Black infant mortality, to really work with our own communities to create what our community wants to see. So Harambee Village was actually co-founded in 2014 right here in Dane County. And we are a collective of birth professionals that come from a myriad of disciplines. And we really work to provide not only direct services to birthing families in the community, but also to support the training and professional development for other doulas of color, other doulas who are drawn to work to support marginalized birthing communities, but most importantly, to really work towards health equity and that policy and systems change that we know has to happen. We've been doing this work in our communities for a long time as women of color, particularly Black women. And so we know what works. We just need to dismantle the systems that are creating the inequities that we're trying to combat as well. So as some of you may be aware, unfortunately, here in Wisconsin, Black babies are dying at 2 to 3 times the rate of their white counterparts. And we've seen an increase. Black maternal mortality is also on the rise here in Wisconsin. Unfortunately, this is nothing new, right? This is a national issue, and it's been an issue since we began really tracking these statistics in this country. And so there's always been these disparate gaps, but particularly for me, I was tired of hearing about it and really wanted to do something about it. And so at Harambee Village, we really are working to make an impact on dismantling these horrendous inequities. Unfortunately, we're also situated in a country that's worse than the nation for maternal mortality and birth outcomes. So across the board, all birthing people aren't safe, and we need to change that. So what we're doing at Harambee Village Doulas really sums it up to 3 things. We are providing access to low or no cost doula services. We do also have a pretty robust private clientele, but our focus is really on providing access to doula services for our most marginalized birthing communities. And our mission is really in our name. So Harambee is a Swahili term that means let's pull together. And it's actually, we took that from history of work that's been done right here in Dane County since the late 80s. And so we're building off of the work that I'll talk a little bit about later briefly. But we're also training. We've worked to secure funding since 2014 to provide training specifically for doulas of color, and have most recently opened that up to other communities who are drawn to this work. And so not only are we training and hiring doulas from the very communities that we're serving, but we're also acting as a community for doulas doing this work, because we can't do this work alone. And of course, those policy and systems change that I mentioned have to happen simultaneous to the impact that we're having in the community. This is one of our very first cohorts of doulas that we trained via a March of Dimes grant when we first started in 2014. And since then, we've trained well over 60 doulas. Most of them identify as coming from marginalized communities, LGBTQ communities. We even have, I think we've trained 5 males now, which, you know, when we talk about diversity, that matters as well. And we've trained doulas in Dane and Milwaukee County, and then we're looking to expand to Rock County as well this year through a partnership that we have there. We've served well over 2,000 families across the spectrum of services that we provide, not only through our doula program, but also through our Family Resource Center. And the majority of the families that we do serve do identify as coming from BIPOC communities. And I would say about 85% of our population is either on Medicaid or Medicaid eligible. Some of the outcomes that we're seeing at the village, and we have seen, is that babies are being born at later gestational ages when they're supported by a Harambee Village doula. We haven't seen any incidences of maternal mortality. That's one thing that's huge. I think oftentimes women aren't seen by a provider until 6 weeks. Some of us that have had babies, we know there's so much that happens in that 6 weeks, particularly for Black women, right, who are at a greater risk of dying from pregnancy-related causes. We see that happening in that first 42 days after we give birth. So because of the close follow-up we have with our doulas, there's been a lot of instances where we've been able to buffer some of those very adverse outcomes. And we have a really high breastfeeding initiation rate, which means a lot, especially when we know that preterm birth or low birth weight babies are really some of those leading causes of infant mortality, particularly Black infant mortality. We know that there's protective factors that access to human milk has in those particular cases. And there's some recent research that just came out really correlating breastfeeding success with some of the hypertensive disorders that we're seeing, or cardiac disorders that are leading to some Black women dying after they've given birth. And then we also have about an 80% breastfeeding rate at hospital discharge, particularly among our largest birthing hospital here in Dane County. But a lot of people ask, well, what do doulas really do? What do doulas do? And you might come across a mainstream definition that doulas are perinatal health professionals that really focus on social emotional support for birthing people, access to information, and that hands-on support that you might see or hear about during childbirth and labor. But at Harambee Village, we take that 5 steps further, because we are doing community-based doula work that I'll talk a bit about in a minute here. But this idea of a doula, right? We haven't always had this word doula. It's actually a Greek word, but it means a woman who serves. And we know across time, across cultures, across humanity, there's always been someone or a community of someones that support birthing people during this process of bringing new life into the world. And so this idea isn't new, although it's sort of the buzz these days. And particularly here in the United States, the legacy of Black granny midwives is critically important to the work that we do. At one point in this country, Black granny midwives were catching all of our babies, no matter what you looked like, until we saw the rise of the medical empire, which is absolutely contributing to a lot of what we're seeing today in respect to birth outcomes. But again, doulas, you know, I think one of the most integral things that doulas do is really act as a facilitator to support that communication between birthing people and that of their birthing team or their medical team, to really negate you know, some of that bias or lack of understanding between the, you know, patient and provider, to really facilitate great outcomes on all sides. However, as doulas, we don't do anything clinical. So everybody's like, well, what's the magic? What's happening? What are doulas really doing? We're really focusing on the social and emotional aspects, right, of birthing folks, which oftentimes gets left out in the medical spaces. And we really focus on health-related social needs because sometimes if a mom is sleeping in their car, doesn't have access to healthy food, doesn't have a prenatal vitamin to take, well, we can't talk about your birth plan, right? There's other things that are acting as barriers and challenges for someone to even begin to think about this time that should be sacred, right, and exciting of bringing a life into this world. And we offer home visitation and really use those home visitation principles to really meet families where they're at. And our visits last, right, more than 10 minutes, you know, like you might see at an OB office. And we really spend time, you know, building relationships and getting to know families in the community. Also offering things like support groups, accompanying families to visits, and then of course that advocacy and policy change work that is so absolutely critical. I won't go into detail, but just wanted to emphasize that there are empirical studies, there's evidence that doulas make a difference. However, I think it's even more profound, I would hypothesize, when we have doulas really working to dismantle racial inequities in birth outcomes, particularly through a reproductive justice framework. And so I think our impact is going even farther beyond what we've seen in the evidence as well. And just a cute note, this baby here is actually the small, tiny baby you saw in the second slide, who's still, his mother is still breastfeeding him, and he's just thriving. And of course, he's cute. So we had to share him. Just another meta-analysis of several randomized control trials that also highlight the numerous positive outcomes when pregnancies are supported by doulas. But the community-based doula work, like I mentioned, is really what sustains the work and gives us hope. You know, we're training people from the communities who want to go back into the community, right, and support other families, other birthing people that have similar life experiences oftentimes. And again, reproductive justice is crucial for us. It's a praxis. It's how we do our work. It's how we live our lives as community-based doulas. And unfortunately, also as doulas of color, we oftentimes are witnesses to those institutional biases that are at play in real time every day when we walk into these clinical spaces. And so we can act as a buffer to that in a lot of ways as well. And just to highlight the reproductive justice framework, some of you may be familiar with, but it's really this organizing concept, right? It's not just a theory, it's how we're doing our work in the community. And so there's a lot of intersectionality that we need to be aware of, and really making those links, right? To laws and policies and how is that affecting our pregnancies and those sorts of connections. And again, recognizing and centering marginalized communities. So oftentimes, because we talk a lot about Black women, Black birthing bodies, people tend to equate our work to only serve low-income communities or only serve Black women. But if we can center Black birthing people, and we can improve those outcomes or have an effect on those outcomes, then we know we're benefiting all birthing folks as well. And so centering our most marginalized communities is really an approach that we're taking in our work. Just want to highlight again that our work is built off of work that's been done right here in Dane County that actually made national news in the early 2000s. The UW-Madison Health and Family Center opened in the early 90s and then unfortunately it was closed in 2010 due to racism, funding, you know, and the like. But what was interesting is that in the early 2000s, we saw the deepest decline in Black infant mortality and Black preterm birth, and it made national news. The CDC wanted to study it. Black infant mortality actually made parity with white infant mortality, and that's never happened in this county. But the elders that we sit with and the stories we hear about the work that was done during that 10 years when the UW-Madison Health and Family Center existed, we know it had an impact on families because of its holistic, collaborative approach that really centered the community and the community voice as well. So what's next for us at the Village? We're excited to be moving into the next phase of our work. This also gives us hope. The Harambee Birth and Family Center, really drawing on that legacy of the Black Granny Midwife, and really, continuing to work through our phases of implementation, starting 8 years ago, really building and talking with other mothers of color and designing what a community-based doula program can look like. And then moving into expanding our reach to family support programming through our Family Resource Center. We recently purchased a building, and we've also recently began our first cohort of midwifery students so that we can then provide midwifery care in our new clinic that we're opening this year as well. We want to create the change that we want to see and that we know needs to happen. And so we're excited to be moving to that next level of catching our babies ultimately, and really providing that holistic wraparound support for families as well. I just want to leave you with this quote. It is imperative that all Black and Brown babies have equitable opportunities to live beyond 1 year of life, and for our systems and institutions to understand how we are perpetuating the residual impacts of the racial inequities that we are all very much well aware of. In addition, just as important is empowering communities and individuals, especially those most marginalized, to feel valued enough to recognize that they have power to permeate systems, right? And that has to go hand in hand with the policy systems and environmental changes necessary. Thank you very much.
Thank you for that introduction, Tia. That was a lot of information, and I feel like there was so much that came out of that that I feel like I have questions about, and we are going to take some time to do a deeper dive, but thank you so much for all of that information and really bringing up some of the things that we're going to talk more about. But I want to make sure to give both Adrian and Jessi a chance to introduce themselves. So we will move on to Adrian next to lead us off with our intro.
Now, you know that is a tough act to follow. Really? You're going to call me next? Okay. Okay, we'll make it fair. Hi, everyone. I'm Adrian Jones. I'm a program manager in the Office of Population Health here at UW Health. And so my primary role here at UW Health is I work on our community health improvement work, leading the development of our community health needs assessment implementation strategy by engaging a lot of the BIPOC organizations that are on the ground doing the work right here in Dane County. And specifically mostly work on our maternal and child health strategies, as well as partnering with local community organizations. And we have the opportunity and honor to be blessed to do some work as well with Harambee Village Doulas, which is an amazing organization right here in Dane County. I don't know what would be the best thing to say, but I think we all know, with a longstanding history of racism and discrimination that exists, of course, nationwide, but specifically in our own backyard, we know that is a huge driver and the inequities that exist for Black and Brown actually birthing bodies here in Dane County. And so I think what's powerful about this panel in itself is that that is a collective goal or priority, is to do what we can to address those outcomes.
Thank you, Adrian. And I definitely want to spend some time talking about the most recent community health needs assessment that was just released not too long ago for Dane County. So we are definitely going to dive into some of the information when we talk about community health. And so finally want to turn it over to Jessi to introduce herself.
Hello. So happy to be here. I am a nurse. I have been working at the bedside in the hospital for UW Health since 2014. And absolutely, my first few years of nursing, it had a huge impact on me. How much of a difference I was able to make in the lives of my BIPOC patients as the only Black nurse in my unit. And for some of them, the only Black nurse they had ever had or seen. or met, so I think it really struck me, and it inspired me to get more active, both in sort of recruiting more nurses of color into the field, but also it made me kind of realize how much of a difference that we can make out in the community as well. I think for me, also going back to school as an adult, and then eventually doing nursing school, I always kind of thought of myself as a little bit different. And I think that for those of us out here who went to college as adults, you kind of feel like sometimes there are internal barriers, that you feel that some of the experiences that held you back from completing, kind of going on that path in the prescribed way are liabilities for you. They are deficits. And I think I learned that all of those experiences that I thought of so negatively were actually the things that helped me be a better nurse to my patients, to be able to provide a perspective that benefited them ultimately the most, So I think that was my first revelation, that I needed to do more. And I was seeing Black women in Madison serving Black women. And I thought, I got to get closer to these people. I got to go to these events. I got to meet these people and see what's going on. So in particular, Lisa Payton Care, who leads the Foundation for Black Women's Wellness, was absolutely inspiring. And just the organization itself, and I kind of started to get as involved as I could, while also maintaining my sort of activity within the hospital. So I ended up kind of having the straddling two worlds of this inpatient world, that I was seeing so much of the impact of what happens in the community, and so I increasingly got involved within the hospital. And at the same time, UW Health was getting its first chief diversity officer, Shiva Bidar-Seeloff, who you can absolutely see the evolution of the institution since in her tenure in leadership. But I learned that I could do both. I didn't have to choose one or the other. And in fact, my experiences with one sort of enhanced my effectiveness in the other. So I became a health ambassador with the Foundation for Black Women's Wellness. And pretty much I am just doing whatever I can to help support their mission, which is to energize, mobilize, and support Black women to transform their health and their lives through education, advocacy, support, and powerful partnerships. And that includes trying to sort of link interested hospital-based nurses who are having some of the same revelations that I had, to sometimes their first opportunity to be able to see their impact outside of the hospital, and how their lived experience can benefit them both in inpatient and out in the community. And actually, I just wanted to just pause for a second to thank you, Tia, and the work that you all are doing, because it's actually at one of your events that I was able to meet some of those elders you were talking about who did that community-based work in the 2000s, and finding that a few of them were nurses and did some of the work that I did. It absolutely has had a huge impact on me, and sort of realizing that I am part of this legacy of Black nurses using what we know to serve our communities in healing. So I just want to thank you for that. I just want to real quick mention that. But I also work at the UW-Madison School of Nursing as a community collaboration specialist in the Brain Health Equity Initiative, which is it's led by dementia researcher Andrea Gilmore Bukowski, also a Black nurse who has just done a ton of work in the field. But really what we do is supporting the advancement of equity in brain health across the lifespan. But that includes, but certainly not limited to, trying to get the information out to where it's needed. So it's not all this information that we've learned stuck in these medical journals, and sort of being hoarded by the research community instead of out where it needs to be used. And especially where the disparities are the greatest. And so, but also really we do all kinds of advocacy within the research community, supporting caregivers, family caregivers and professional caregivers, and just connecting people to all kinds of resources to support them. So again, just continuing to find more and more value in combining lived experience and professional experience, you know, to support my community.
Thank you, Jessi. And again, I thank you all for being here. The work that y'all are doing is so important when we talk about hope. I think one of the things that we don't talk enough about is this hope that we can bring healthy people into the world. That's something that is so basic of, like, you know, bringing healthy babies into the world, making sure that their mothers are, you know, healthy and taken care of. It just those small basic things that seem like we should know how to do after how many years of you know, human civilization, that we still are having conversations about how to do that. And so for me, seeing the hope in, like, people working on this issue, because it is important, and it probably is just like the most basic thing that we can do to ensure, you know, a healthy community, a healthy environment for all of us to know that is happening. And so just my first question, I want to tie this to, again, Adrian's work as a part of, like, the community health needs assessment, and just want to talk up, like, this document, if folks in the audience haven't seen it, is so amazing, the work that goes into it. And so definitely, like, snaps for Adrian and all the work that goes into preparing this information, but just tying all of this idea around, you know, maternal mortality and the numbers for, I mean, Tia brought this up around what it looks like, but the numbers are really startling when you look in that document, that it's like, I think it's 50 Black women out of every 100,000 of the population die in childbirth, versus 17 for all women, and then 14 for white women specifically. So that number alone is, I mean, 50 lives is a big deal when we talk about 50 people, but when you, in comparison, like, the fact that this number is like the norm for us, like that would be the baseline for anyone, is startling. And it's like, why is there not these red flags raised? So I do want to talk a little bit about that rate, and how do we bring that into like the community-based healthcare that you all are talking about. And I know everyone touched a little bit on it, but what are the ways that we really educate people about this issue and bring it to the forefront and give it the attention that it should have and that it deserves? I don't know who wants to go first, if you have an answer for that.
I guess I'll just jump in more so with a coined term or phrase that came out of Reproductive Justice Collective, especially when Miss Loretta Ross was the executive director, and of course now Monica Ray Simpson is, trust Black women. It's as simple as that, and sometimes you have to repeat it multiple times in all the spaces that you're in, because when it comes down to trying to figure out the solution, it goes back to the fact that we are the experts. we are the experts on what's happening in our community. We're the experts of what it is going to take to move the needle. But not only that, our community is filled with, a robust amount of knowledge and wisdom, and recognizing, Tia touched on that too, the intergenerational wisdom that is passed down from our elders. It's that, that wisdom is passed down. And so I think just remembering that this work isn't new, is that it's been going on for however many years. There's just more tools and resources now. But again, it goes back to the whole idea of trusting Black women, and even just kind of mentioning the community health, needs assessment. A big part of the community health needs assessment is engaging community. It's finding out what they are seeing, what people are seeing, what people are hearing, what people are experiencing, and taking that and what is said to be, potential solutions to figure out a plan to improve some of those outcomes.
Absolutely. Yeah, thank you. Tia or Jessi, either one of you want to share anything more?
Well, I kind of touched on it a little bit. I just think, just to kind of piggybacking off what Adrian said, this stuff isn't new. And I think there's also an aspect of sort of recognizing that the kind of knowledge that's needed as valuable, because we sort of, prioritize certain things, and we say, if this adds letters onto the end of your name, then that has value, and we need to recognize that the kind of knowledge that is changing the game here it doesn't come with letters that go on the back of your name. And so I think there's an aspect of that lingers even when you have people sort of going out in the community and, trying to do important work. There's still sometimes that like lingering feeling that like, well, this is like additional and this is nice and stuff like that. But the recognition has to be that this is urgent. This is important. This kind of knowledge, it has to be at the forefront. This is what's making the difference, not just an additional thing, but this is like the thing,
Yeah, and I think we also get so caught up on individualizing the issue, when I think in reality, the medical empire needs to educate themselves. There should be a whole history course or a whole semester, year, really digging deep into the history of the medical empire in this country, and how that is very much the same today. It just looks different. And so, trusting Black women, well, we didn't do that when we had Black granny midwives producing great outcomes. We poo-pooed them. We, tried to streamline them. Now you have to get a doctorate in midwifery to be really seen as creditable. And so we continue to increase barriers to access information or education, if you will, and oftentimes want to individualize the issue and say, well, we need to educate those moms more, they need more education, when in reality, they have what they need. They just need to be heard. They need to be seen. And so I think oftentimes we're spending a lot of investment on the latter, right? And not really investing time educating the institution that's really killing us in a lot of ways.
Yeah, agreed. And that is a great question for you, Tia, for follow-up with doulas. And, like was said, there is so much, given to people who have those, extra letters behind their names, and this fall back to probably a over dependence on medical services, especially when it comes to the birthing process, even though douulaing is something that has been around forever. And before there were hospitals, people figured out how to bring babies into the world. And so just curious about any pushback you get as an agency when you are promoting doula services and trying to get people to engage in doula services over like seeking out more traditional or now considered traditional means of birth? And what does that look like for you all as you are growing your organization?
Yeah, I think we absolutely get pushback. Doulas across the board get pushback, but particularly because we're a Black-owned organization, you know, centering Black birthing folks, we get pushback even more so. And I think, you know, when we think about safe birthing, it doesn't always have to be in the hospital. It doesn't always have to be outside of the hospital. I think understanding sort of the cultural roots of supporting other people in labor. And, you know, oftentimes people really don't understand doula work. And it's interesting, when I first started this work, you know, there wasn't a model, right, on how to do this work, right? We just know our histories, right? Community mothering. And I had a lot of white doulas in our community here say, you really shouldn't do that. You shouldn't offer free doula services or volunteer-based doula services because you're going to ruin it for the rest of us. Well, thankfully, I didn't listen to them. And I would actually have to say a lot of the policy changes we've seen, like doulas are now allowed in the operating room at one of our hospitals, is going to affect all doulas, all birthing families, right? And so, you know, this idea that, you know, you can't do that. Thankfully, we didn't listen to them, because we're seeing impacts for all doulas, all folks doing this sort of reproductive justice work, all birth work, and for birthing families across the board. And so absolutely a lot of pushback within the own doula profession, within our own profession, within the medical institution as well. And our doulas face that every day going into these birthing rooms. But I can tell you, most often when we're done in that birthing room, we have nurses who want to train as doulas. You know, we've now made connections and relationships to medical providers. And that's where we're able to really create true change in our community.
Thank you for that. Yeah, and so this term has been mentioned a couple of times, but if we could just go around and each one of you talk about as far as like reproductive justice and what that looks like for you all, and how you are seeing this show up in the work that you're doing. If everybody wants to go around and just talk a little bit about that.
For me, freedom and self-determination, I think, is one of the biggest, one of the first things that come to my mind, because, you know, if we think about so many barriers at this time to what may be to the use and the prioritization of that generational knowledge, that I think, you know, breaking down those barriers it's just the first thing that comes to my mind when I think of reproductive justice.
When I think of reproductive justice, I think of the right to bodily autonomy. I think of me having the right and the choice to parent or not parent, or to choose how I want to parent, but also to be entitled to quality care across the spectrum. And by that, I mean the life course. And so when you think about reproductive justice, it really is about coming from a life course perspective, and not just starting at conception or pregnancy, but looking at it from the pediatric side of things. And so making sure we have those healthy birth outcomes for our babies, because what happens in the womb tends to set up what that baby is going to have to deal with when you know they come into this world. So if that birthing parent is stressed and dealing with housing or food insecurity and things like that, that stress of course impacts their own health, but also the health of their baby. And so that's one aspect. And then from as far as the work that we're doing, so, you know, Beth, you had mentioned our community health needs assessment. The priority health outcomes that came out of our community health needs assessment were behavioral health, injury prevention, chronic conditions, and we focus on maternal and child health, but this cycle we went with reproductive justice. And the reason for that framing, or as a health system calling that out as a priority, is one, recognizing all bodies that are able to give birth, not just kind of looking at it as like, just focusing on pregnant women, but just all birthing bodies, and recognizing the need to be have gender inclusive prenatal care, making sure we're incorporating, staying grounded in health equity, but also realizing that it's more of a full scope of care. It's not just in the OB, prenatal care appointments, labor and delivery, but it's in primary care, it's in behavioral health, and aspects of social determinants of health, social justice, dealing with racism, and how that all together compounds to the whole person. So there's that piece. The other part of it is that, when we think about mental health, Black maternal mental health is a rising huge issue here across the US. We saw it rise during the pandemic. It basically became exasperated, especially dealing with both a global health pandemic and a racial induced pandemic, which we've always kind of been in, but now it's more visible, and the stress that causes. And so again, just recognizing how all of those things come into play for a person's reproductive health, and how that, again, it falls under the umbrella of reproductive justice.
When I think about reproductive justice, I think about basic human rights. That's what it's all about. That's what it's built off of. It's a universal set of human rights that applies to everyone, birthing bodies, non-birthing bodies. I think about intersectionality and how we oftentimes miss those, confounding factors that lead to, not having the high quality care and the things that Adrian talked about, and access to food and those sorts of things. And I also think about these ideals of motherhood and how society has sort of, they have their own lens in which they see mothering and what is good mothering, what's not good mothering, and particularly for Black women, when we talk about the social work space, reproductive justice also gets at these ideals of good or bad Black mothering, right, if you will. And, that's why, reproductive justice, is connected to the CPS system, right, to our social work system. It's connected to all sectors in a lot of ways. It's connected to substance use disorder, right, and how we view who's a good mother and who's not a good mother, or who needs access to particular services and who doesn't. I have a family that we're working with right now who is dealing with substance use issues. And I've wondered, her kids weren't taken away necessarily, but I've wondered if it would be a different picture if this was a Black woman, right, who is having trouble overdosing, right, and not taking care of her kids. And so we're seeing those differences, right, in real time, still happening today. And so when I think about reproductive justice, I think a lot about these ideals of motherhood that we have. But of course, as Adrian mentioned, it's so critical that it's not just about birthing per se, right? It's about our overall health, and that this isn't something specific to maternal child health. Chronic disease, right? All sorts of things are impacting our ability to have healthy pregnancies or to choose not to have a pregnancy. And so it's more than just maternal child health. And I think we have to take a much broader perspective when we're really thinking about something like reproductive justice and radical hope, because I think we're missing the mark in a lot of ways, and really are much narrowly focused when we should be thinking more broadly.
Absolutely. And I love how all of you talked about, like, this is more than just like, whether or not to have a baby, or, how you have a baby. This is across the lifespan. And we are really talking about, how we just provide and how we continue to, care for each other. When we talk about like community-based care, reproductive justice is at the center of that, and providing that for people. And so I do want to get to some of these questions because there are a lot of questions coming up in Q&A. So I want to make sure to get to all of those. And Tia, you touched on this a little bit, but there was a question specifically about, does your organization work with women with substance abuse disorders, like methadone treatment, since methadone is the safest for women with opioid use disorder diagnosis?
Yes, thank you for that question. We absolutely do. And it's really disheartening to witness the experience that these mothers have in our healthcare system as well. And it also goes back to these ideals of mothering, right? And, unfortunately, many of our states have laws, that will punish, mothers for using during their pregnancy. And so there's so many layers there that need extra support. And fortunately, during my time at ARC Community Services, we worked very heavily with pregnant women or women with young babies really struggling with substance use disorder. And what we don't realize is that substance use disorder goes hand in hand with severe trauma. And, we call ourselves being trauma informed, right? In every discipline and field, the healthcare field, social work field, whatever. But we're really not if we're not understanding that those two things go hand in hand. A pregnant mom just doesn't decide one day, I'm going to use drugs to harm my baby, right? So we help unpack that with all of the systems and providers and case managers that these pregnant bodies are encountering throughout their care. And oftentimes these women are also scared to go in. We just had a mom who thought she might be in early labor. She's, she's using methadone, and she's just scared. She doesn't want to tell her story again, right? She doesn't want to have to be judged going into the emergency room. And we really gently encouraged her that, no, you do need to be seen. And so it's sad the way that women struggling with substance use, particularly pregnant women, are treated within our systems. And we absolutely do see them as a marginalized population that needs to be lifted up as well.
And I think you've mentioned a couple of times with social work, and child protection is a huge component of the social work field. With the program at UW-Madison, it is their part of that is a child welfare focus or children, youth, and family focus, and just kind of addressing what are some of the issues within the social work field that have some of the same issues we talk about with like between, the medical field and with doulas, but also in social work, we see that of like child protection is called on to deal with these issues that maybe could be handled with some other community resource. But again, it's tied to this professional view and the letters behind your name and who you represent, and we're missing out on actually listening to the folks impacted by these things to provide the services that they need. And so that is one of the questions in here, is just I'm curious to hear the panelists' thoughts on the social work profession. There's often the same push as the medical field. And so how is the social work profession viewed in the work that you do and with the individuals and families you work with? For those of us who truly want to engage at a community level, what advice might you give? I'm hearing listen as a theme already, but what other advice you might want to give to social workers?
I don't know if this is necessarily advice, but more so what we constantly hear from the community. Oftentimes we have Black birthing patients who might be discharged with unstable housing or even transportation. And so when they're screened to ask, like, do you have stable housing, transportation, things like that, there's that fear, which is rooted in racism, on if I tell you I don't have stable housing, or when you discharge me, I'm going to be living in my car, that more than likely you're going to call CPS because already you will just deem that I'm an unfit parent. And so it's really kind of having those conversations and understanding that there's I guess you could, I mean, we've all probably said it, a tale of two cities, if you will, a tale of two birthing experiences. You know, if someone who is not a Black or brown birthing patient says that they do not have stable housing and really needs resources, of course, they're going to get those resources, but they're also not going to be viewed as an unfit parent. And so, you know, again, that tags along with what Tia said about how mothering is viewed, especially for our Black and brown birthing patients. And so just to put that story that has been out in this community for quite a while. So it tags on to the current medical distrust that already exists.
Yeah, and I think in social work, just like, you know, I can speak specifically to nursing, I think, you know, it's so important to listen, right? But to be constantly evaluating what you feel like you know. You know, I think we sort of underestimate the extent to which we were educated in an unjust system, that the things that we learned were that as fact or as the standard are based on the exact thing that people are afraid of when they don't want to tell you the whole truth. You know what I mean? That whole system is what we're educated under. So I think it's really important to sort of question how is my first sort of how am I contributing to stigma and labeling the person in front of me before I even say anything? How am I making assumptions based on, you know, maybe what I learned that might not be true, you know, or that might actually be harmful? And how am I contributing to the problem? You know, I think that is sometimes the hardest thing to look in. It's easier to point the finger at a big problem than to look in a mirror and see the way that you're contributing to the problem. So I think, you know, to the point that was already made about trust, you know, I think that it's important to kind of be constantly evaluating so that, you know, our professions can evolve. You know, I think that's the goal. Like, you know, we have to, as we're acknowledging that these numbers are people, you know, and that it's unacceptable. 50 lives, 14 lives, like it's all unacceptable. But the only way that it's ever going to change is through, you know, us changing, the person in the mirror changing, you know. And so I think that's what I would say. That's what I would say.
For us at Harambe Village Doulas, we're doing social work without a social work degree. And when we were really designing the model, we built our model off of infant mental health principles, because I think that really gets at the heart of social work. It forces you to evaluate things within yourself. That then gives you more compassion and empathy that you can bring to a clinical space. And it helps you, you know, take off that expert hat and really just be with families and be present and really build off of the knowledge that they do have, and to build those relationships. I think oftentimes we come in as the expert, right? Let alone the whole, you know, racism that's involved and the bias that's been involved for years, and the way in which a lot of communities, marginalized communities, view, you know, this idea of social work. And oftentimes we don't see people that look like ourselves in those spaces. And so, you know, I think someone asked about how to get more involved with the community. I would encourage you to take infant mental health course. There's one at the university, or to really dive into infant mental health, early childhood and family mental health principles, because I really think it gives a broader perspective on how we can support and be with families and do good social work, right? Without necessarily, calling ourselves social workers, if you will. And I think when that can happen, we're able to be much more effective in supporting families and build trust, because, that's what's lacking in respect to the social work field, I think. And so, finding ways to, I think Jessi mentioned, it starts with ourselves. So finding ways to really be able to sit with those things and process those things and change, that'll then transcend into your professional space when working with families or getting into the community as well.
Yeah, and I think what often happens when you talk about education and professionalism, we forget that at the core of social work is community, and what you all are doing, we may not call that in social work, we may not call these things social work, but being in community, working with the community and serving the community is the core of social work. And so, you don't have to have a license or a degree or certificate to know that and to do that work. So I appreciate all of that was shared, and really for all of us in this field to be thinking about that as we do move forward to engage the community in changing the things that we're talking about here. And there was a specific question around nursing for you, Jessi, and just a question about is this a part of, is this idea of racism and maternal health or maternal mortality and infant mortality, are these becoming an ongoing part of the curriculum in nursing schools? Is that changing at all? Are you seeing this become more of a broader topic in the nursing area?
I would say change is slow. I think that things are being I think the way that things are discussed is just as important as the fact that they're being discussed. And so I think that what you have, and again, as I talk about, the way that we're educated, and the fact that the system is unjust, it's who's teaching, right? And so it's not just about those who are practicing, right? It's also about those who are teaching. And so the evolution is ongoing. So I would say that there's still quite a bit lacking, but what's really interesting is I'm seeing so much push come from students. And that has been just so inspiring to me, to see that. And as we talk about, we hear so much talk about generations and the younger generation. And, as we get older, we always see things that the younger generation just doesn't get and they're not doing right. And I have just been so much of the hope that I have for the future is based in the fact that, we've got people, these young people are not letting it go. They have demands. They have expectations. They want to be prepared to be able to evolve these systems. You know what I mean? They want to be out here doing good work. So I think that change is slow within institutions, educational institutions included, but I think that the push can come from anywhere. So I am inspired at what I'm seeing, including the young people who aren't letting the issue get dropped. So I'll say that.
And there is a question along those lines of, for each one of you, how do you see encouraging more people of color, more Black women to be involved in the work that you're doing, that is community-based, and building that up to create those pockets where people who are coming for services, whether that's birthing or healthcare needs, they see people who look like them and are representative of, who they are in their communities.
I think for us, we go into the community. We don't sit behind our desks and expect that the community is going to come to us. And it's been interesting. Our doula trainees are getting younger and younger, and it's quite fascinating. And speaking on what you were mentioning earlier, it's hopeful, and it's reinvigorating, and building trust in the community has also allowed the community to trust coming to us, so that we don't have to do as much outreach, right? We're creating those connections in the community. You can think of it like a spider web, and they're just growing and growing every year that we do this work in the community. We have grandmothers who want to come and do the work, right? Because of, they didn't have something like this before. We got teenagers who aren't even out of high school ready to get down and get dirty and do reproductive justice work in the community, right? We go to nursing schools and present. We host family medicine, residents, right? So we're bringing them outside their walls as well, right? Because it takes a village. It truly takes a village. We can't do this work alone. And so, getting out into the communities, bringing folks into our community, and really trying to permeate the medical industry, right? Mostly through education and curriculum, I think will be most impactful. And so, those are some examples of ways in which, we're getting out there and connecting with the community to really spur that radical hope and radical love that's needed to sustain this work for generations to come.
Sorry, I had to see the question one more time in the chat just to make sure I understood correctly. In terms of encouraging other people to get into this work, I feel like it's two parts to it. One, it's always cool when I see like I have a long history of working with youth, particularly doing girls programming. It's always cool when I meet high school students or even middle school, even elementary school students who are like, what? Like, so explain what you do. What does that mean? So people actually do this. We actually do this. And to be able to say, yes, like we do this, the work is, the personal is professional. It's very much interconnected. You really can't separate the two. And so in terms of encouraging people to get involved in this work is basically saying that in order to do this work, it almost comes from lived experience, and your lived experience is your day-to-day. I feel like that's what drives us to try to make change. I think the other thing, and I feel like that's kind of been mentioned a few times, is that when we think of like public health or healthcare, what is actually considered public health. And so changing that narrative to be more broad and inclusive, and it not just being about letters behind your name, because that's where things kind of get mixed up, is how can we consider ourselves like, public health professionals or public health advocates, and what does that look like? So changing the narrative and the image. And saying and telling these young folks, like, just see yourself in it. You're doing this day to day. Those young people have been on the front lines during this pandemic, are fighting and rallying for change, racial injustice, things that are happening in their schools. So they're doing public health. They just don't know it. And so the thing is changing that narrative and the imagery.
I love that. I love both of the answers already given. And I agree that I think, as I kind of mentioned about my own story, I spent so much time thinking that, You know, I didn't belong in spaces where actually my voice was desperately needed, you know? And I think that it's, well, I think also as we're seeing a lot more of, you know, we're seeing in our communities, these for us, by us solutions, and we're seeing the impact. And I think, you know, being able to see someone, just kind of like was already mentioned, being able to see someone doing it makes it real for you, you know? And so, and I feel like, you know, once those of us who are at these tables and you realize, you know, that the stuff that you know from your life, you know, the stuff that your community members know that is what is going to change things. You know, that is what's missing when we talk about like why we've known all of this information for so long. This study was done or that study was done 20 years ago. And we were like, oh, this is urgent, but it's still changed. It still hasn't been changing. Well, that's because the people who have the answers aren't at the tables, you know what I'm saying? Aren't in the institutions making the change, making the decisions. And so I think I totally agree that I think it is changing that narrative and, you know, to let people know that like you are exactly what's needed. That idea that you have of who you're supposed to be, that's already there. If that's already there, that person's already there, not making the change, not knowing how, you know, not knowing how. So I agree. I absolutely agree that the things that that lived experience will bring you is what's called innovation. That's what's called innovation. We call it that, you know what I mean? But it's really like some of what people are already doing in their homes and in their communities.
Yes, to all of that. that was much needed, and a reminder of, you know, our expertise is our lived experience. That's what it is. And bringing that and talking about showing up as our full authentic selves to do this work. That is key to all of this. And so I want to keep getting through these questions. There is a question, y'all know this is coming, about this pandemic panorama, whatever we want to call it, that is going on, that we are dealing with. And just if anyone wants to speak to the impact that it has had, that you've seen on healthcare and access to preventative care. And then there's also a question here about any thoughts to share on vaccine access and availability.
I almost said panoramic. This pandemic feels ongoing, but in short, we were kind of shifting into an endemic, which basically means, you know, COVID will kind of at some point have the thought process of it being almost like the flu, where, you know, there's vaccines, those will continue to get better over time. The flu will continue to evolve, just like we know COVID will continue to evolve. But in terms of what we see in the healthcare system, and I'm going to kind of go between healthcare and community, is that, especially thinking about the inequities that already exist, is there probably been a lot more home births, I would say, during the pandemic, because a lot more birthing people are, especially when we think about maternal mortality, morbidity, infant mortality, is which one increases the likelihood that I'll survive? Will I have a better likelihood chance of surviving if I give birth at home and have less of also risk of exposure to COVID? Or is it better to be in the hospital, and if something for whatever reason goes wrong, at least there's, you know, medical staff that can immediately get to me? And so I think the change is more birthing folks are deciding which setting is going to increase my life expectancy, if you will.
Yeah, I'd absolutely agree with Adrian. When the pandemic first hit, we saw a huge influx of families wanting to switch their care to a home birth community setting, or we're just very alarmed at sort of the restrictions that have been put on laboring people. For example, birthing families are only allowed one visitor. And when the pandemic first started, that also included doulas, but we picked up the phone right away and called both of our hospitals and said, you know, you can't count doulas as the one visitor. We are part of the care team. And if you think about that, you know, again, it's like, who gets to decide, right? The birthing population, I think, is getting overlooked a lot in the midst of this pandemic, right? We're going to the hospital to birth a baby. Most times we're going to the hospital because there's an issue, right? Or you're sick, or we need to treat you. But unfortunately, that's not how we've been viewing birth and birthing bodies. And so there's a lot of fear that already existed around birthing in a hospital clinical setting that has only been, you know, exaggerated or increased because of a lot of the restrictions that the pandemic has put, you know, on who can come to a clinical appointment or who can be there for your labor. And, you know, oftentimes different cultural beliefs or values, they want or need their whole family there. They need their sister friend, they need grandma, they need mom. And so we're limiting access to what birthing people need to really feel supported and safe in these spaces where we oftentimes don't feel safe, right? And we're doing this calculation that Adrian talked about. We have a lot of families still to this day doing that. And we're seeing a lot more families birthing in the community, which is safe. You know, 5% of babies are going to have a little bit of trouble when they're born, and only about 1% really need that in-depth, you know, medical support. So, you know, in addition to that, you know, there's of course all the other ripple effects, right, of the economy and, you know, access to healthy foods, rental assistance. And so we found ourselves becoming an agency that was doing all the things, right? We're doing birth work, but we're also helping people pay rent, utilities, delivering healthy groceries, because again, that we know that all of that goes into, you know, reproductive health. But also very alarmingly, we've seen a lot more inductions and a lot more C-sections. And I'm really curious to really look at some of the data and the outcomes that are coming out of, you know, what we're calling birthing in the pandemic, because it's been very alarming for us in the doula world, you know, sort of how we're trying to move people through, but not really realizing we're causing more harm than we are, you know, good. And so there's some interesting trends that we're seeing in the medical space. And then again, all those other ripple effects sort of confounding this fear that already existed about being able to birth safely in a hospital is that much, you know, it's greater than it has ever been before. And then we also have some hospitals putting restrictions on doulas now, which is interesting. Now you have to provide proof that you're trained as a doula or you're a certified doula. And so we're seeing these repeats in history, right? What we did with midwives, we're now doing with doulas. You know what I mean? We used to not let husbands come into the birthing room. You know, now we're putting restrictions on visitors. And so it's really interesting that we haven't been a little more innovative or creative in respect to supporting birthing folks, birthing families in this space, you know, right now with the pandemic. It's really unfortunate, but families are resilient in a lot of ways as well. So we're seeing, you know, a lot of self-advocacy happening at the same time. So it's not always bad, you know, it's sort of sparked people also to think about birthing differently, as Adrian mentioned, which has always been an option to us as birthing folks. And so we're seeing a lot of those interesting trends as well.
Well, I can't speak to the experience of birthing and how that has changed in the pandemic. However, I will definitely say that I have seen, even before the pandemic, to me, the impact of stress and chronic crisis, if you will, in people's lives was a huge part of what I saw, particularly in general medicine. I now work in oncology. And so I think I've seen, I continue to see stress, the stress of isolation, to a great degree, just sort of playing itself out, unfortunately, for all, all of the reasons that we kind of discussed. So it's ongoing.
Yeah, and I do want to touch on the mental health piece, because earlier we mentioned, again, the community health needs assessment, and mental health, I believe, was like one of the top issues across like every race, every demographic. It was the top, and we are all going through this, the stress of living through this pandemic and the uncertainty of it, and the strain on, us individually, but also all of our systems. And so for you all in doing your work, how is that showing up for your work? And kind of what do you see as, like, when we talk about the overall theme of this conference, the hope of like that being at the forefront? Is there anything you see or hope to come out of this, more focus on the mental health aspect of when we talk about, like, our overall well-being as a society, and then on our healthcare system and its kind of needs for people's needs? Hopefully that all made sense.
Well, I'll just say, I hope that we're starting to sort of recognize that thinking of mental health as its own separate category of care and resources, and it is just not realistic. I hope that we're starting to see that mental health impacts every part of the way that we care for ourselves and each other. And this is another part of the way that we're educated and the way that we learn. I mean, in nursing and in, medicine and those kinds of fields, we mental health, like that's, well, you got to refer them to somebody, you know what I mean? And it's absolutely, it's tragic, honestly, to be really honest, because when we think about the impact of stress and even the physical impact of bathing our brains in stress hormones from the times that we're born, and the adverse childhood experiences that often are a result of our parents, the stress that our parents, were born into and experienced throughout their lives. I mean, when you talk about chronic conditions and the way that people are or are not able to manage that, and the fact that often these things are framed in individual behaviors. And that's actually the whole, and how racism plays out in that way, but I think, I hope that we're learning as I think it has become harder to pretend and to put on a facade of being fine, and mental wellness has kind of come more to the forefront of conversation, and become more normalized. I'm hoping that what will come out of that will be, talking about mental health holistically and in every conversation, no matter what field you work in, and recognizing that it is, and trauma and mental wellness is going to be an important part of the way that all of us are educated. So I'll leave it at that.
Bethany, as you mentioned with the community health needs assessment, I mean, literally for every single population, mental health was it. And I think, just thinking about the pandemic being in the background, is that in 2020, we're trying to figure out how to survive. In 2021, we're trying to figure out how to live. In 2022, we're trying to think about how to thrive within this circumstance of a pandemic and all the things that continue to go on around the world. When you think about our youth who were maybe accessing mental health services, to when things shut down, they were having to have telehealth visits at home. And some things that we heard from the youth is that, well, I don't have the same privacy And what if the reason I'm seeking these mental health services is because of people in my house? So what do I do? Where does that leave me? And then when schools closed and moved to virtual, you have that isolation. And I think the isolation was felt across the age spectrum, especially for our elderly population who often sometimes gets missed. Their need for mental health services increased during the course of the pandemic. Some of the things from the system level that's being done is working on embedding behavioral health services or mental health services within primary care clinics. They also are in pediatric clinics for our system. But I think too, on a community level, specifically in the Black community, we've really seen the need of our folks need mental health services, and that stigmatization that went along with needing mental health services has been gradually dismantled during this pandemic. It became the norm of conversations to say, hey, I need to talk to somebody. I need a therapist. I might need antidepressants. And it became a norm of a conversation. It wasn't anything that ostracized someone or made you look at them, any differently. I've heard the framework of mental hygiene versus mental health. And so to give the perspective of the same way you take care of your body, the way you shower, you bathe, you wash your face, apply that same thinking or behavior to your mental health. Your mental health needs to be kept up to par. It needs to sometimes be washed a little bit, by talking with someone, and to work through, I'm going to just do some kind of analogy here, the trauma being like the lint that just, you can't get rid of it until you start to address it. You can't keep sweeping it up, type of thing. And so I think just the realization that the pandemic forced us to recognize that we all need, mental health or mental health service access. But again, that stigmatization was something that was very big in our community. And I think, again, recognizing that, we have to make it more accessible. So if you've noticed, there's been a lot more partnerships within the community around access to mental health services. Anesis Therapy and Mount Zion Baptist Church, their partnership is one example. But, because there are so many people that are in need of mental health services, it's extremely hard to get in for an appointment. That was an issue kind of before the pandemic. And then now when you have an increase in the population that needs access to services, the wait is longer. And then we also have shortages for healthcare staff. And so it's, you kind of burning at both ends, trying to figure out how to make it work. But I think, again, mental health is still something that is a huge priority for the health systems. And the thing is just figuring out, based on our current capacity, what can we do, because we have to make it possible for people to actually be helped.
All the things, everything Adrian and Jessi said, particularly for birthing families, it's been so hard for them to access mental health services, even more so these days. So we've, had to get innovative in that respect and try to bring in our own mental health partner, because we were feeling lost for where to send folks. And oftentimes we just had a teen mom who's like, they make me fill out this form every time I come in, but they don't do anything about my responses. So it's like, sometimes we're just screening to check the box, but are we really sitting down with folks to hear and listen to what they need, and bridge those services until they can get in on a 16-week waiting list or however long it may be. And so I think we need a reinvestment and a redesign in how we look at mental health. I think Jessi mentioned this, that it needs to be more holistic. It needs to be part of our overall well-being, not this sort of separate thing in a box over here. But again, we've seen a huge uptick in postpartum depression or postpartum anxiety, but still there's a fear around that, those ideals of motherhood. Can I, even within this conversation and dialogue about the pandemic, if I say how I'm truly feeling to my provider at 6 weeks, because remember, we have to wait 6 weeks to see a provider postpartum, how are they going to view me as a mother? Can I be honest that sometimes I feel like I want to throw my baby out, I'm like, I can't do it today. And to not feel judged and to not feel stigmatized and, wanting to be able to access more support, I think is a critical conversation that we need to have. It's infusing everything, that we do, as mothers, as birthing people. And so we need that holistic approach. And I think ACOG is now talking about seeing women or birthing folks sooner than 6 weeks, which I think is huge when we talk about mental health screening and those sorts of things. So I think, again, we need to re-innovate, redesign, and reinvest in mental health, because we know it affects everyone. And when we talk about maternal mortality, it's also one of the leading causes of women dying, right, after they've given birth from mental health issues that aren't addressed. So, and again, the pandemic, I can imagine, has only made that quite worse. So we need to reinvest, we need to rethink this idea of mental health support or mental health as, in general, to be open to maybe doing it a little different. And maybe the pandemic has spurred us to do that a little bit more. I know we're very appreciative of a postpartum telehealth program that we have in partnership with a high-risk doctor at Baird, specifically supporting Black women. And we actually wrote this program, before the pandemic. So we were really grateful, and we've really seen the receptivity and the needs that women have. And thankfully, we've been able to sort of provide some mental health support, but we really need to do this on a much larger scale in our community and across the state and the country.
Yes to all of that. And to definitely bring in mental health to the forefront and trying to get us all out of this. My 5-year-old niece says this pizza party, pandemic, whatever you want to call it, whatever works. Yes. And I don't know who put me in charge of keeping time, but we are at time. It's 3:32. Thank y'all for sticking around. I want to just again thank our amazing panelists, Tia Murray, Adrian Jones, and Jessi Kendall, for being here today, for sharing their insight and expertise and knowledge with us. This was a really great conversation. Again, all of the sessions are being recorded, so y'all that are still watching can go back and watch it, tell your friends about it, have them watch it, all of that good stuff, so they could get some of the information and knowledge here. And yeah, please make sure to check out Harambe Doulas, learn more about them. Actually, our closing session next Friday is featuring Ali Muldrow, who is a birth doula, and Oceana Sawyer, who is a death doula. So we will cover that spectrum that we kind of touched on here. So make sure, if y'all are not registered for Friday session, that you do, so you can hear more about that. And again, thank you to everyone. Please make sure to complete the evaluations. And the link was put in the Q&A, but you should get an email about it. And hopefully we will see you all next week. Thanks, everybody. All righty, we are good. Nicole, are we all good with ending?
Yep, we're good.
All right.
Great job.
Thanks.
Thank you.
Thanks, Jessi.
Yeah.
Bye.
Bye.